Good afternoon. It's my honor to have the chance to share our experience in our innovative nasal surgeries to everyone. So today I want to discuss more about the surgeries about OSA, and also despite the pharynx surgery, we also do a lot of nasal surgeries. And is there a way to do it more minimally and under local anesthesia and treat both the obstruction and also the rhinorrhea and nasal itching together? So that's what we are going to discuss today. So in terms of conflict of interest, I have nothing to declare. So as we know that poor sleep quality is related to poor nasal functions. So according to our patients cohort, we found that over 80% of patients will have moderate to severe poor induction sleep when they have moderate AR to severe AR, and which impairs our life quality a lot. And for allergic rhinitis, it's not only the nasal obstruction or congestion, it also has some postnasal drip or nasal itching. So when we try to treat these patients, do we have a method to control these symptoms together, aside from just septal rhinoplasty? So the ICAR 2023 had published a guideline to treat the chronic rhinitis, including allergic and both non-allergic, and they introduced the inferior tribunal surgery as level of evidence B, and which can control the rhinitis pretty well. And also there's a new treatment, including cryotherapy and radiofrequency ablation of posterior nasal nerve. And while there is not very much level 1 evidence, so it's level C right now, but we believe that as the evidence accumulates, it will become better in the next version. So, but where is the posterior nasal nerve? It comes from the brainstem. It goes all the way from sphenopalatine foramen in anterior nasal cavity, and there is 3 main branch. The largest one goes to anterior inferior branch into the inferior turbinate, and the posterior superior branch goes into middle turbinate, and there's a pharyngeal branch going to your pharynx. It goes around your eustachian tube, which causes your nasal postnasal drip. So this is a picture by Peter Womar, and he had a beautiful dissection showing that the nerve goes all the way behind the sphenopalatine artery, and it goes into the lateral nasal wall around the eustachian tube and all the way down to the inferior turbinate. So that's where we are targeting. So the first modality introduced in the US is cryotherapy, and we can found that the target area is around the middle turbinate and the intersection between the inferior turbinate and eustachian tube. And this is the frozen therapy. So the first literature showed that a great improvement in the symptom score from 60 to 60.2 to 2.6 in 30 days, and the effect lasted for 1 year. And meanwhile, they also found that for allergic patients, the symptoms seem to a little bit, it's still good, but for a non-allergic patient, it looks even better. And there's another device, it's the radiofrequency ablation of PNN, and it's FDA cleared in 2020, and it uses thermal injury by RF energy, and it treats 3 zones, including the lateral nasal wall and the inferior turbinate posterior aspect, and also the septum swell body. So there is already like 2 3-year follow-up from the randomized control trial showing these devices had adequate control over their symptoms, including rhinorrhea, nasal congestion, nasal itching, and sneezing. And the response rate was good. It was 70 from initially and comes to all the way to 87 to 2 year to 3 year. And there's another device is Neurant, and it also published their 2-year study. And similarly, they also concluded that the PNN can cause a durable control over their rhinorrhea and the nasal congestion symptom. And worth noticing that they also have published the first result that the PNN can also control the eustachian tube dysfunction symptoms. So they found a significant improvement in EDTQ7. And and which control their oral fullness and eustachian tube dysfunction symptom. And there's another new device is in China, and they had developed and also temperature-controlled radiofrequency device, and they compared the PNN neurolysis to PNN neurectomy and found similar result, which also showed a really promising result. So after all these studies and other several literatures, the AAO and ARS has supported use of posterior nasal ablation to treat the chronic rhinitis, and this should not be think as experimental. But several questions raised. First, that these devices are most available only in US and not available in the rest of the world, including Europe and Asia. And there's still a space to improvement for their initial response. There are nearly 30% of patients not respond to this treatment. And by that means 30% of patients have received, like they spend $33,000 and they receive nothing, and even there's a risk of complications. So I think this is a room for improvement. And in the 2024, the IFAR published a complication report that 2.4% of patients may encounter a posterior bleeding after these devices. So is there anything we can do to improve these problems? So this is what we are trying to develop. It's a new trial to combine two modalities, including Salon Pro. We treat not only the anterior inferior turbinate, but also the posterior inferior turbinate, which, as we can think that the PNN goes all the way from the lateral wall and enter the inferior turbinate, and that's where it goes in. And as we know, inferior turbinate is the largest organ to produce nasal obstruction and rhinorrhea. So this is where we target first. And the second part, we use a CO2 laser to target the lateral nasal wall to emphasize the lateral nasal wall segment of PNN. By doing this, we collectively call them RPN3. It's combined with RPN, radio frequency or posterior nasal nerve, and the laser posterior nasal nerve ablation. So actually what we did was, this is the CO2 laser probe, and we will treat also the superior aspect of the posterior inferior turbinate a little bit. And then we start to ablate the part between the middle turbinate and inferior turbinate and around the eustachian tube. And by doing the local anesthesia, patients quite well tolerable. It's not really that pain. And after we complete the procedure, it will look like I draw a red line. This is where we treat. And so this is the part where we do a Salon probe and enter the posterior aspect of the inferior turbinate, targeting the intraturbinate segment of posterior nasal nerve. And by doing this, we destroy the nerve inside, but it doesn't cause much bleed, and we don't need the nasal picking afterwards. So this is the first literature we published. We compared the two procedures. One is the combined procedure we call RPN3, combine the Salon and the laser lateral wall ablation, and we compare it with the RFIT alone. And we found that the RPN combined treatment had a significant improvement in terms of RTNSS when comparing to RFIT alone. So we want to explore what exactly helps. Is it in the nasal obstruction or the rhinorrhea? So we had another retrospective cohort study. We include 101 patients, and both groups works pretty well, because in the RPN group we also targeted the inferior turbinate posterior segment, and there's still a significant difference between the two groups. And when we look at the 1 month, 3 months, 6 months follow-up, the RPN3 group, they start from somewhere like 8.2 and down till the 1.2, and which was significantly better than the RPN group. For the nose score, there is no significant difference. So when we look at the actual component of different subscores, we can find out for our RPN group, there is still severe rhinorrhea until 3 months and until 4 months, and there is some still itching sensation during the RPN group. But for the combined approach group, there's always mild to moderate symptoms, which we found that these two parts is the most significant part when we combine laser treatment. So this is another study we've done to justify that using laser PNN alone. This is a randomized control trial, and this is the interim report. And we found that when comparing to Chien group, we performed it in a control study. We used the same local anesthesia, and we did not turn the allergy on. And we found that the laser group had a significant improvement in terms of RTNS in the 3 months, and the p-value is 0.03. And also we found that the sleep quality had improved in the PSQI, that there's no significant difference. And the ESS score had come from 8.9 to 5.1, which had a significant difference. So our overall outcome, we found that the 3 months responder rate was 94, which was really good because perhaps we combined two approach. And the RTNS improved was 83%. The no score was very significant, improved from 95%. And so we're thinking about who to operate on. We should not operate everyone who has nasal obstruction and chronic rhinitis just because they can't sleep well. So this is another study. We divide the patients according to their preoperative RTNS score. There's a 1 to 12. And we found that when we choose the patient only RTNS is more than 5, their response rate can up to 70% in the first month and up to 90% in the 3 months later. So it is optimal to choose patients with moderate to severe symptoms to obtain high responder rate. And this is another study when we give this surgery to rhinitis medicamentosa patients, and we follow up for 1 year. And we found that when they receive RAPN alone, there is no significant change in terms of itching and the rhinorrhea and sneezing. They have significant difference, but you will wait till after 6 months. But when they receive RPN3, they had a significant difference since the first month of follow-up, and it lasts for until 1 year. So for this procedure, we combined two modalities, and the most concern is about the increase in the complications. So we previously reported 2.4% of major bleeding in posterior nasal cavity. And I think the most important part is do we identify the vessel root. As these vessels comes all the way from the lateral side of lateral nasal wall. So this is one of my cases, and there is a minor bleeding initially, and when we look at inside, there is a vessel bleeding. So that's where the vessel comes from. So ever since I tried to identify the vessel's root, so if you can look, take a closer look, there's a position here, and this is the part where the spa goes all the way down from the lateral wall into the infiltrate. There's a small position here. And so this is another video, we can check that. There's a position right here. So if we didn't look carefully, we could ablate this area and cause an aneurysm and delay bleeding like 3 weeks later. So now we just give us 2 to 3 millimeters distance, and we ablate the anterior and posterior part, and the risk of bleeding could be minimized. So this is what we obtained. We had reviewed 400 cases, and we calculated complications. Most of them are self-limiting, including rhinosinusitis, necrosis, and there's only one posterior nasal bleeding, and there's a majority of cases are anterior nasal bleeding. And meanwhile, we also found that when we divided patients into OSA and non-OSA group, the OSA group had a significant, much more risk of complications when compared to the non-OSA group. So we performed a new univariate analysis and a multivariate analysis. It found that the OSA is an independent predictor of all complications and hypertension, and OSA is the independent predictor for major epistaxis. So in conclusion, Chronic rhinitis is associated with poor sleep and quality of life, and the posterior nasal nerve neurolysis is a potential treatment to treat this condition. So we have shown that laser posterior nasal nerve neurolysis is safe and it could improve RPN lenses compared to sham surgery group. And when compared with RPN group, it could add additional benefit in rhinorrhea and sneezing control. And we have to notice that for patients with hypertension, obesity, and diagnosis also are major risk factors for post-op bleeding, and we should have shared decision making to make sure the patient understands the risks. Okay. I want to thank our hospital, the Vincent Medical Foundation, Chai Hospital, and HME University to conduct this research. And I'm finished. Thank you.